Well, hello, everybody. Good afternoon or good morning, depending on where you are in the country. So glad you joined us. My name is Garrett Schmidt. I'm the managing editor for VBC Exhibit Hall, and I'd like to welcome you all to today's live webinar hosted by Lightbeam Health Solutions. And this will be a good one. I got a little bit of a preview of it and excited to hear from our speakers today. And it's called Maximizing Healthcare Efficiency, how deviceless remote patient monitoring saved a physician-owned practice $1.5 million. So you're going to get some inside scoop today, and again, very excited about the content. A few items of note before we get started. This is a traditional webinar format, so it's not the type of thing where you have to turn off your camera or your microphone. Don't worry, we can't see you, we can't hear you. But we do want to hear from you. We're going to have a time for some Q&A towards the end of the presentation. Now, if you have a question at any point, go ahead and use you'll have a little module there for where you can ask questions, which is different than the chat. Go ahead and drop your question in there at any time. You don't need to wait until the Q&A to do that. And we're going to get to as many of them as we possibly can during the allotted time. We have a lot of material to cover and a big audience today too. So if we don't, again, get to your question, don't worry. Someone will reach out to you through email afterwards and make sure we answer your question. So even if we're wrapping up at the very last second, go ahead and drop your question in. Finally, the session today is being recorded. So what's going to happen is about an hour, maybe two at the most, you will receive an email after the fact with through the same email you registered through, and there will be a link to the recording as well as to where you can download the slides, and there'll be the information about how to get in touch with these folks if you'd like to. So without further ado, I wanted to introduce Shelly Davis, and she is the VP of Clinical Strategy with Lightbeam Health, and she's going to introduce our other speakers. So welcome, Shelly.
Excellent. Thank you so much, Garrett, and thank you for inviting me. It's such an honor to be here, and I'm very excited to be joined by Nicole and Katie. As Garrett mentioned, my name is Shelly Davis. I'm the Vice President of Clinical Strategy. That's a fancy title. I am the population health clinician for Lightbeam Health Solutions. I'm a registered nurse and have been for 30 years, and I've got my 30th year reunion coming up. It just reminds me how long I have been in this particular space and in healthcare. My role at Lightbeam is to bring a clinical lens and perspective to everything that we do. We are a data-driven care orchestration company that includes robust analytics, a deviceless remote patient monitoring program, which you're going to hear more about today. We also have an extremely powerful AI engine that surfaces non-clinical factors that drive social determinants of health. And once we can identify them, we can solution for them. Something I'm very passionate about, but I'm even more passionate about being a nurse. I have, as I said, spent 30 years in this space. I started out at a trauma center in Philadelphia, and I think nursing is such a great career because I have worked at the bedside in critical care. I have been a flight nurse in the military. I have worked as an educator, a care manager, and now serving as population health clinician. I'm very passionate about the frontline workers that are impacting patient and member lives every single day. And I'm thrilled to be joined by two of them up at Mankato Clinic. So Nicole Krennick is a bachelor's prepared registered nurse. She is the clinical manager at Mankato Clinic for care management and Daniel's Clinic in St. Peter, Minnesota. And she's worked at the clinic for 12 years, has been a registered nurse for 20, and she also has a passion for care management. And her goal is always to ensure that she and her team are meeting the patients where they are and ensuring that the care that is provided is patient-centered and holistic. Katie Dessner is an LPN. Also, she is the Care Signal care manager at Mankato. Care Signal is our deviceless remote patient monitoring program, which you're going to hear more about today. She has been at Mankato for 22 years, 20 of which she was a primary care nurse. As I mentioned, she is the Care Signal care manager, and she manages the Care Signal dashboard and the panel of patients that Care Signal helps to manage. She addresses all the alerts, looks for trends, and then develops pathways for when she starts to see abnormalities. And then she works closely with the care managers and providers to provide education and assistance to those members. Katie or Nicole, anything you want to add?
No, thanks for the nice introduction. Excited to be here.
Excellent. Jason, may I ask you to advance to the next slide? So we're going to just talk very briefly about value-based care. This is obviously something that is not a new concept. It is CMS's goal to have every Medicare or CMS eligible member to be under a value-based care arrangement by 2030. There's a lot of pressures on providers and organizations out there, some of which come from the pandemic and some lingering effects that we see there. Rising healthcare costs, the pressures and the identification of disparities in outcomes as they relate to social drivers of health, and how we can identify those, how can we solution for them. And those I think, and I look back at even 30 years ago and well beyond that, when I was at the bedside in a trauma bay, we knew many of the social drivers that were impacting care. And I think we wrung our hands over it as an industry of how do we identify them? How do we solution for them? How do we change the trajectory of these particular patients? And being able to be able to close the gaps from a social disparity is also a pressure. And of course, then the rising healthcare costs as well as staffing costs. And it's not just staffing and how to make staffing more efficient and how to scale programs. It's the cost of paraprofessionals as well as just the availability of them. That also is lingering effects from the pandemic, where we are seeing behavioral health and social workers, paraprofessionals leaving out of that in droves. Of course, my own nursing community, I sit on an alumni board of where I went to school, and we are seeing not as many applicants. We're also seeing retirement of nursing professors, which means we don't have the dedicated, talented staff to train the next generation of nurses. But yet, how do you deliver care to members under all of that? So again, value-based care is not something that is new. It is something that has gone through many iterations through CMS, but this is something that we do know. And we do know that patients who are under managed care arrangements have better outcomes, they live longer, they have better quality of life. And so it is capturing, and it's also moving the needle on spend. So it is capturing the goals that we intended for it when BBC was rolled out. And so we are excited to see that 2030 coming so that we can maximize and optimize the number of members that are in those arrangements. There have been a lot of changes in the Medicare Advantage world, and so we were seeing skyrocketing enrollment, and it was actually outpacing other value-based care lines of business. There have been some changes in the managed care or in the Medicare Advantage space. And so with that, we're starting to see some of the enrollment slow, but still incredible opportunities out there to drive better outcomes for that particular population. Jason, next slide, please. Excellent. So I think this is a great slide when we talk about how do you approach a value-based a population health strategy and how do you best manage care. And when I look at this, and I mentioned in the intro that I came from a care management background, and we looked at the top 3 to 5%. That is where a care management program and a traditional care management program is the backbone to any successful value-based care program. Those are where you leverage people like Nicole and Katie and myself to provide that human first, human touch, frequent touch point of those patients that they are your sickest, they are your greatest utilizers, they either have complications from their conditions, or perhaps it's years of condition mismanagement. They're the burning fires in front of you, and it is absolutely critical that you manage that particular part of the population, that top 3 to 5%. And then I look at the rest of the iceberg that is on the screen, and I refer to those as the if only patients. That is the next 20% down. It's how do you wrap your arms around that 20%? Those are the patients who, if only we had known about their cut on their foot well before it became infected, and now they have a forefoot or a below the knee amputation. What if only we had been able to solve for a medication adherence or a medication availability issue much earlier in the care trajectory before they end up in the emergency room and then have a mandatory observation stay or an avoidable inpatient visit. And it's really challenging to wrap your arms around that lower 20% unless you go out and hire an army of care managers. And so, how do you then scale your program, identify who are those if only patients as early in the care trajectory as possible, but also to look at, and what literature has shown us is of that 20%, about 1 in 5 will escalate up into the highest risk population. We also know people want to stay healthy. So, how do we identify who that 1 in 5 is going to be? How do we give them the tools and the resources they need to delay their progression into that top 3 to 5%? How do we keep them on the path to self maintenance and to wellness? And again, how do we identify those patients, those sort of needles in a haystack, before they show up on a care manager's roster as having had an acute event? And again, it's very challenging to do that without going out and spending a lot of money on staff. It's also unfair and unreasonable to ask staff to continue to do more with less. And so that's when we have to look at technology and how can we leverage technology to be able to manage those if only or that lower 20% of the patients. Jason? Excellent. We also want to look at, and I think the pandemic has shown us a couple of things. One, I just lost what I was just going to say, but from a sense of when you're handed a group of problems, and the word is escaping me right now, but innovation comes from that. And so I think that there's been a lot of innovation that comes not only from a technology standpoint, but from a services standpoint. And when we also are talking about normalizing behavioral health. So the pandemic not only taught us innovation and required us to have innovation, but it also helped us to normalize the conversations around mental and behavioral health. It also showed us what loneliness truly looks like and what loneliness can do when it comes to chronic conditions. What we have known for years is that with chronic condition, there is an undeniable link between behavioral health, depression, and those that have chronic conditions. What we also know is that patients who or members who have a chronic condition and depression cost more than each of those conditions when standing on its own. So we put some numbers up here. From a depression standpoint, I would say that the typical patient spends $2,100 to $2,600, similar to diabetes, but any patient that is diagnosed with both of those conditions tends to spend 2 to 4x that amount of money. And so we want to make sure that we're not only addressing just chronic conditions and chronic symptomatology, but also ensuring that we're providing holistic, whole person care, and ensuring that we're addressing behavioral health as well. Next slide, please. Let's talk about Mankato and our partner. And again, we're thrilled to be joined by them today. Mankato Clinic is in Minnesota. They have 190 providers, 90 physicians, and 100 advanced practice providers. They have 11 clinics located in 5 different communities, and they also have additional specialist outreach to 8 additional communities. Their primary care is offered at 5 different locations. They have 30 different specialties offered, including maternal health, behavioral health, gastroenterology, endocrinology, surgery, wound care. It just runs the gamut. They also have 850 employees, 79,000 clinic visits, 380,000 lab tests, 35,000 imaging studies, and 800 OB care deliveries. And yet Nicole and Katie have found time to spend a little bit of it with us today. So Jason, may I move to the next slide, please? So we're going to hear more about their strategies and what they implemented very successfully in the work that they are doing for the communities that they serve. And Mankato, as mentioned, is a physician-owned practice and health system, and they have done incredible things. It started out with a simple thought: how do we best serve our community and make sure that we're taking care of our community, because this is where we live, and that is something that Mankato lives and breathes by. They also have a foundation that funds local community organizations. Some of it's the library, some of it's providing BMX helmets, just a tremendous opportunity that they're using to be able to surface opportunities and to be really in partnership with their community. So as we look at how overall moving from a fee-for-service to value-based care space, again, value-based care is not new, but many providers are still standing in two canoes where they have their fee-for-service revenue that's based upon value, and then they have their value-based contracts. And we often get the questions at Lightbeam, and my team especially, how do we leverage changing the, how do we know when to take on more value-based care arrangements versus fee for service, and we typically look at about 40% of revenue and about 20% of a patient panel. So when a 20% of a patient panel is under value-based care or value-based care eligible, that's when we start moving into taking more value-based care contracts. Of course, value-based care started with upside only, and now we're seeing the added pressures of taking on downsided risk. And so again, how do we look at, and there's several different levers that we pull when we talk about how do you successfully move from fee-for-service, again, which is all volume-based, to value-based care. There's a couple of different levers, including looking at network management, perhaps expanding your panel, capturing those patients that don't yet have an assignment under a value-based care contract, or also being able to generate revenue, including from a CCM perspective. Jason? And so with that, I will include Nicole in the conversation as we talk about some of the strategies and some what they looked at, because as mentioned, they were in previously upside only contracts. And then in 2022, added 35,000 patients into downside risk and knew that they couldn't ask their staff to continue to do more with less. How could they be successful? How could they continue to serve their community as well as serve their providers? And with that, they became partners and deployed CareSignal. And Nicole, I'm going to turn it over to you and ask for additional context and what your goals were in partnering with us.
Yeah, so as Shelley mentioned, we had been working in value-based care in the sense of care management for a long time with that high-risk top 5% spender population. We definitely were noting, along with that downside risk, that there was a huge potential to impact those middle of the rowers, we call them. I think that was that rising risk area that Shelley talked about, that 20%. And we knew there was a huge ability there to impact the high spending that comes with some of that. If we could get ahead of, a brand new disease before it got to the point of flaring and frequent flyers to the hospital and ED, that sort of thing. We were sitting with our care managers having between 80 to 100 per care manager. We had about 8 care managers that were at each family practice sites, our pediatric sites, and our internal medicine. And our CMO actually approached me and asked, how might we, tackle some of this, be able to expand that value-based care model. And so that was a perfect opportunity. He had heard about CareSignal, and from there we just met with them and decided it would just provide us the ability to expand that model to a much bigger population and to really meet those 20% or so of rising risk patients that we weren't able to touch before. Next slide.
So as Nicole mentioned, the goals of partnership were really to be successful in fee-for-service and value-based care to increase opportunities, enrollments, and revenue for CCM, as well as to reduce avoidable admissions and avoidable utilization. There's a couple of different reasons for that. Yes, it is that there is excessive cost associated with it, but that's also what we know is that medication errors happen, fragmentation happens, poor quality of life. We overburden the health system. We overburden the front end providers that are sourcing in the hospital. And our goal is always to provide longitudinal, continuous care, and we can achieve that through CareSignal. We also wanted to be able to scale the care management capabilities, again, to be able to not only efficiently and effectively manage that top 3 to 5%, but also to wrap our arms around the 20% that we just would not be able to otherwise do with a typical human first care management approach. And we like to refer to CareSignal as a digital first care management approach that then that complements the traditional care management program, which again is truly the backbone of any successful program. Nicole, did I miss anything?
Nope, I think that covers it. I didn't talk a lot about the CCM, but that was another huge component. We were having to meet a lot of measures around that with the shared savings and then that downside risk. And this was a great potential as we focused on Medicare patients.
Excellent. When you talk about leveraging CareSignal to keep members healthier and keep them in the community, oftentimes when a member gets to the point where they present to the emergency room, they need to be seen and they need to be treated in the emergency room. And of course, there's been some changes, some regulation changes that now mandate either an inpatient stay or an observation stay, which again, it creates additional stresses not only on the health system and those that are working in it, but also the patient. And that extends to their family if they miss work or they're creating family stressors or they happen to be caregivers to spouses or other family members at home. So it's really critical that we're identifying and being able to keep members as healthy in the community as possible, and identifying where some changes, whether it's education, whether it's getting them into their provider earlier, whether it is medication reconciliation or just relevant symptom education, how can we intervene on a much earlier in the care trajectory so that well before they show up on the emergency room, well before they show up even on a provider's radar, how do we surface that? And we talk about CareSignal as nobody can hide from our technology because we are a deviceless remote patient monitoring program. We also have a very successful remote patient monitoring program in terms of the outcomes that we stand by. And we were recently named by KLAS the #1 remote patient monitoring program for 2024. And that's something that we're very proud of. But we are deviceless. We looked at technology and thought if we deploy and build a solution that anyone can use and we truly meet the lowest technology functioning group, that we would and be able to drive success, then those that are well equipped at using technology are also going to be successful. And our initial thoughts panned out. We, as I said, we stand by the results that we have. And we do that through, again, a low technology approach, and we're leveraging the technology that everyone already has, whether it's IVR through home phones, which we found about 62% of Medicare eligible aged individuals prefer to use that mechanism. But we also have the ability to send text messages through flip phones like my dad had, through smartphones like that I have. There's no apps, there's no passwords. Again, it has a very low technology entry point, and that leads to its success. Again, we are almost fanatical about ensuring that we're meeting members and patients where they are. We want to make sure that we're identifying opportunities. So all the CareSignal program outreach to members is written on a 4th to 6th grade reading level. It is available in multiple languages, and we want to be able to promote and really elevate from a social determinants of health that we are bridging and meeting those members. We have 13 clinically validated peer-reviewed articles, including JAMA and the New England Journal of Medicine. And then although our interface is very simple, and you'll see it in just a moment, there's a powerful engagement that's happening behind it, and powerful AI that's keeping members on the program. And we have some members who have been on for 10 years. On average, it's anywhere from 12 to 15 months. We've had many clients that have had patients on the program for 3 to 4 years, being able to, again, deepen not only their knowledge, their adherence, but also deepening their brand loyalty with their primary medical home as well as their health system. It's any solution solution is only as good as the amount of people using it. And so we are thrilled with our engagement results as well. Jason. You can see the different condition programs that we offer, and then just some of the results: 62% decrease in hospitalizations for COPD, 46% decrease in CHFBD visits. We're driving improvements in appointment adherence, as well as behavioral health scoring, and then hypertension we're seeing across chronic conditions, including 1.15 point drop in hemoglobin A1C. And many of our organizations already had robust care management programs when they deployed care management. So this is not low-hanging fruit. It's not like they've gone out and selected a whole new group of patients. These are patients who were being well managed and then are just seeing even better results with CareSignal. Next slide. So again, very simple interface, very easy to use. And then Nicole and Katie are going to talk a little bit about how they've deployed the solution through at Mankato. You'll have my contact information at the end if you're interested in it. But it's really, they are the stars of the show. They're the ones who are driving the outcomes for the people in their community. So I'm going to turn it over to them. And it's the folly of a live webinar. The word I was looking for is adversity. Adversity drives innovation. So Garrett, if we can go back and splice that in, you'd make me very happy. Nicole.
We can go on to the next slide. And I am at work, but they have decided to mow, so I apologize if you hear a lawnmower in the background. But I'll start with just kind of how the whole process starts. So on our end, we worked with a large group to kind of get this underway. We pulled in our quality support staff, and then as well as my care management team, and then our operations department to kind of say, in what order should things go into, to make this successful, make sure we get the lists out right and all that stuff. So at the very beginning of every quarter, quality pulls a report based on the qualifying diseases we have chosen, and then their insurance type. We chose to focus on Medicare and medical assistance because that's where most of our downside risk lied, and we already had value-based care type models going on with chronic care management, healthcare home, which we have in Minnesota. And then that gets sent over, that quarterly list gets sent over to CareSignal, and they then will do outreach to our patients for us. If we had to do that outreach, there would be no way we would be able to enroll all these patients. So that is a huge plus. We worked with our marketing department as well and CareSignal, and together they work to put out emails, letters, etc., text to the patient, just letting them know they'll be getting this call. So it's not a completely cold call and the patient can be expecting it. Once they're enrolled, the CareSignal enrollment specialist will give them a call, introduce the program, suggest to them that their provider would like them enrolled in this program, and then they also do our chronic care management enrollment on that call as well. So that is nice for us too, because it allows us to continue our chronic care management work and get credit for that with doing this model of care, which is a perfect fit. We're assessing chronic disease and we're digging deeper for these patients. From there, as patients are enrolled, Katie gets a list that just indicates who actually said yes, and she enrolls them on our end. And I am going to let her talk in just a minute, kind of how that looks for her. So she enrolls them on our end, and we have to do that to allow that, make sure we have a care plan in place for them, because we need that for chronic care management and then our other value-based care programming. And it's nice to have a care plan in there as well, because it provides patients some instruction, some health education that engages them. These calls come frequently for them, but it engages them when we're not available. So Katie's doing those alerts 8 to 5, Monday through Friday, but the weekends come and et cetera. And so it does provide them with some guidance on how to take care of that. And if they were ever to unengage or go on vacation, it gives them a little bit of education on what to do then. Once they're enrolled in our system, from there, Katie is monitoring the dashboard regularly for live alerts that come through for her, and then any trending data that would indicate that we need to get ahead of that. for the patient and work with the care team. So I'm just going to let Katie speak to that in-depth work a little bit more.
Sure. So I'll just give a brief summary here. When patients report to the Care Signal program, we are alerted on our dashboard if the data that they entered is outside of the thresholds that we have set. So we tailored the thresholds for each of our programs based on best practices, quality measures, and our clinic goals. Some of those thresholds can also be adjusted per patient, which is really nice. When an alert arises, I research their condition, I review their medical record, I review their care signal data, and then I reach out to the patient just to check in and see what's going on. We have workflows in place. We have those home action plans that Nicole was speaking about that the patient has on hand to review. And then we have written protocols in place for each of our programs kind of to use as a guide for me to when I should message a provider or when an appointment is needed versus when the patient should present to our urgency care or the ED or call 911. The alerts are in real time, therefore I'm often able to connect with the patient within hours, sometimes even minutes, depending, on my day. As Nicole mentioned, all the data that's reported to Care Signal is collected, and then based on the thresholds we have set, it categorizes each patient in either a low risk, rising risk, or a high risk category. So patients that are in the low risk category are meeting their goals. Those in the rising risk category are typically not prompting an alert, but they're kind of approaching that threshold. So that's where we really found the opportunity to prevent disease progression and provide some early intervention for those patients. So these might be patients who have a blood pressure that's trending up, blood sugars that are out of range, increasing PHQ-9 scores, or as the symptom critical. So that's when we get my notes here. That's where we kind of step in. So patients in this category are monitored. If their data remains in that rising risk category or becomes high risk, then I contact the patient just to review the data, review their chart, talk about their symptoms, confirm their medication and disease management compliance. And then this is where we found an opportunity to provide some education for the patients on better home management of their disease. We have printed educational materials that can be mailed to the patients for guidance and for reference. If the patients continue to hover in this category, this rising risk category, that's when we might reach out to their provider for some guidance or make them an appointment for follow-up. And then the patients that are in the high risk category, those are typically patients who are already alerting, so we're already monitoring them very closely. A couple other things I wanted to mention, since we've not yet integrated Care Signal into our EMR, the data can super easily be pulled into a PDF to be shared with the provider. It can be printed. I often print those reports for providers as like a pre-visit planning so they can review it with the patient at their upcoming appointments. And then all the time spent working in the Care Signal program, I'm able to collect at the CCM time.
Yeah, and part of the enrollment process too, when we create those care plans, is we do provide a flag in the system so that the providers do know when we're involved. We have 5 or 6 programs now. We started out with 5, and that was hypertension, depression, diabetes, COPD, and CHF. And so it is alerted in their chart what type of program they are in for the provider to see. We now added asthma in the last year. So that's a little bit about our workflow. We can go to the next slide. So one thing we found very early on was building buy-in with the providers was very important. We had actually kind of started out thinking we would remove the providers as much as possible because, again, we already do value-based care. We have a lot of things going on at the Mankato Clinic, and for the providers to think of one more thing to enroll their patients in or talk about seemed overwhelming. And we quickly learned, because of all Care Signal was doing, we didn't have to sell it that way. It was more that they just needed to know what it was, and then also really find the benefit in utilizing the data that Katie was receiving. So we started to add a newsletter, which we were sharing internally with providers on a regular basis. And this kind of just showed the success rates. Were we meeting our goals? What kind of cost savings were we seeing? We even provided some real feedback from patients who were saying they felt more engaged. And we showed them those drops in some of their quality measures and things like that, that really helped kind of sell that when the patient walked in then and said, I got a call from an enrollment specialist, should I sign up? The providers really knew that, yes, you should sign up. And they had a direct contact because we had clinic-facing material. Then they could just hand to the patient with Katie's number on it so that Katie could explain more. They at least had buy-in to encourage their patient to stay in the program or sign up for the program. Next slide. So now I'm going to talk a little bit specific to the outcomes we're seeing. This is a really exciting, I mean, all this stuff is very exciting. You know, these numbers to see are great on our end. We had been doing value-based care for a long time, like I said, and we really just never had numbers behind it. And that's one nice thing about CareSignal as well, is it provides regular feedback on what is this work doing, what is it providing. This is utilization, so you can kind of see the number of messages we're getting and the volume. So we had high text and phone volumes, but remember that it's an automated system. So we only see the high risk alerts, which were there about 5,000 in that time, and then trending concerns. So trending high risk, of course, alerts are priority for Katie in that day. As they come in, she addresses them as they come in because they need, you know, they are at risk of potentially hitting the emergency room or the hospital. The trending risks are there once those are managed for Katie to look at, so we can hopefully keep them out of that high risk category. So that leaves us at a pretty manageable workflow for Katie. We also have several that still work with their traditional care manager, so they may take on a few of those alerts too if it makes more sense, rather than with continuity of care, dividing that work. We've had about 3,254 have been enrolled, and that puts us at about a $1.5 million cost savings, with 122 ED visits averted, 2.3 drop in A1C for those greater than 8, and a significant decrease in systolic blood pressure, and a 10.5% decrease in PHQ-9 scores. So all around, like I said, it's just very exciting numbers to look at as we watch this program grow. Next slide. So overall enrollment, as of 1/31 of 24, here is how many patients had enrolled in each program. So remember, asthma had just been added about a year ago, and each patient can be enrolled in up to 2 programs, but we wouldn't go beyond that. And CareSignal helps risk stratify that, what makes the most sense if they have several different types of disease processes, what puts them at highest risk, and they help divide that out for us. Next slide. Before rolling out CareSignal, it was noted by other value-based models that mental health really seemed to be one of the biggest drivers of cost. We had always noted trends that chronic disease could be somewhat managed, and we could get those patients more engaged, I would say, not always. But when we also added in the mental health component to disease, it did tend to drive misutilization much more than if they were dealing with less comorbidity. As you can see, almost half of those with chronic disease enrolled have depression as well. So we really pushed that depression was one of our first programs because of what we were seeing with the mental health background. Next slide. And this is our alert summary. Again, on average, since as of January 31st, our population, per our population, is 2.4%. Another way this dashboard monitors is, you know, that's another way that it's manageable. So only 2.4% alerted out of all of those patients. And so that allows Katie to be able to manage all those alerts coming in throughout the day. And Katie, what would you say an average day looks like with alerts?
Yeah, so currently I think we have just under 2,000 patients in the program. And I'd say, you know, it just varies. You know, some days there's 6 alerts, some days there's 12, 15 alerts. It just depends. And then I'm also kind of chasing, I called a patient yesterday. They didn't call me back yet today. So you're always kind of chasing those alerts from the day or two prior.
Okay. Just to give you some perspective, we can go to the next slide. And I won't read all of these key insights, but again, as we go through these outcomes, just super fun, exciting outcomes that we're seeing. So we had an average drop of 2.3 in A1C, which is a great selling point for our providers, our quality team, our administration, all of that. Next slide. Hypertension, again, our systolic blood pressure dropped significantly. One thing we did find with hypertension is we did have to tweak these questions just a little bit. And sometimes per patient, Katie can adjust the alerts a little bit. So we had some people alerting if they were dropping too low. So we had hypotension alerting maybe more frequently than our cardiologists and our primary care were needing. So we did change some of those outcomes, or I should say text messages and phone calls, just so that those questions fit more of what we needed and then didn't alert and it alerted at a different phase. But hypertension, it's been great to see the drop in especially systolic blood pressure rates. And then next slide. And I should mention with these outcomes, CareSignal does a great job every quarter going through all of this with us. And so this is some of the stuff we share in our quarterly newsletter to the clinic as well. So depression, 82% risk improved. So of the 45 starting in red, 35 of them moved to low risk, 2 to rising risk, and 2 to rising risk improved. So again, very exciting. The middle bullet is a great outcome. 91% of risk improved, 92% of low risk maintained. And then you will see of the 122 alerts indicated they felt suicidal. So before we were able to roll out the depression program, Mankato Clinic worked very hard with CareSignal just to make sure that if we were taking on depression and we felt like there wasn't a liability there when they received these text messages or these phone calls and they said they were suicidal, what was happening. And these patients do get a call from a crisis line right away in real time. And so with that, it took away that liability from the clinic. Of course, Katie still follows up with them. It's just we know there's something happening for those patients, so they're not sitting out there at risk when we may be out of the clinic or unable to get to it in real time.
And I can see that on the dashboard. It shows me that the patient was connected and that a connection was made. And it even shows me how long their conversation was, how many minutes and how many seconds. So I can be assured that they truly were connected.
But this was great to see with depression. I think sometimes when patients come into the clinic, you see a little bit more of a standard PHQ-9. Sometimes their numbers don't move. I do feel like it's a bit more accurate on the phone. There are some that will always be high, but meeting them in real time and these regular follow-ups is a little different than when they're actually coming into the clinic in crisis all the time. So next slide. So again, just a bit more review of depression numbers and kind of what we were seeing with their depression categories. Great numbers, great outcomes. The more severe their depression, of course, the less we sort of saw that flux, but we have less patients maybe in that area, and it does allow us to bring them in more quickly, I feel like, with their care team when needed. Next slide. Again, as we mentioned earlier, Mankato Clinic had experienced trends that indicated those with mental illness tended to drive utilization and cost more than chronic conditions alone did. And so this, just you can see these outcomes, they just sort of reaffirm that that was the right choice to make sure we were starting with depression as one of our programs we provided to our patients. The analysts suggest the patients managing comorbid chronic and mental health conditions experienced improvements to both conditions that are equal or greater than those who manage just one condition. So it was good to just kind of have that reaffirmation after doing this for so many years in traditional care management sense. This reaffirms some of that. Next slide. So this is a great slide. Of course, it shows cost savings, which we love to see, and we need this to prove that we can keep continuing these programs. But again, just as you all saw with the title, we were able to save 1.5 million in estimated medical costs avoided. And this is shared on the regular quarterly basis too, what we're seeing with cost savings, and regularly shared with our clinic. And this is the driver to allow us to maintain this programming. And very quickly on, we were seeing cost savings. So that has been great to watch. Next slide. Also, when we started this, as Shelley and I both mentioned, increasing our chronic care management was part of the return on investment. We were asked to have 200 patients at least billed monthly once we started this programming. And just a little bit of background about that. So we went from having about 3% of our patient population being charged out for chronic care management when we started, when we were doing traditional care management. So at the beginning of CareSignal to up 15%, and at the current state we're at 17% where we're charging out. So it drastically allowed us to increase, and of course met our ROI when it came to CCM, which also impacts our downside risk. We had to get to at least 5%, and we much surpassed that. We're used regularly by our ACO, which is who's monitoring our CCM rates, as examples of how to get our CCM levels up. So next slide. Now we'll talk a little bit about provider experience. This is a predictable and manageable workload. That's one thing I'll kind of stress. Again, we had care management before. We were working with high-risk patients with chronic conditions, but we were typically the ones initiating contact. So we were trying to guess when they needed our contact. You know, we have some workflows and algorithms, etc. CareSignal really allows the alerts to drive us so we can be at the right place at the right time, which has been very helpful. Otherwise, we may have missed flares in the past, preventable events, that type of thing. So it has been very helpful that way. And again, the average alert rate is 2.4%, which Katie has been managing well. As we increase, I think, disease types, if we do, or different types of programming, we may need to look at that. But at this point, it's been very manageable with Katie managing that dashboard. Next slide. So this helped balance out traditional care management for us and CareSignal. So you can see there's sort of this ebb and flow. We were able to move some of our care managed patients that were really high intensity, you know, but managing fairly well on their own. They really just we needed to stay ahead of those flares. We were able to move them into that low intensity bucket. So Katie could manage them and then reach out when needed, and then vice versa. Katie can also reach out to us for traditional care management when very appropriate. So there are some regular frequent alerters, some we can do more with than others, but she can also involve a care manager at that time to do more education, to dig deeper on more of a specialized care plan if needed. Those are our RN level workers, so we can change that care plan a little bit and work beyond the protocols that Katie works with for those patients. But it's been really nice to balance that capacity on both ends. Frequently pushing patients back and forth, whatever seems most appropriate. Anything to add to that, Katie?
Nope, that's, yep.
Okay. Next slide. And then patient experience. I'm not going to talk through everything verbatim, but very strong numbers as far as engagement in general. I just feel like Katie could attest to this too. It feels like because of this, patients do feel like we truly do care and we're wrapping around them and want to know if they're doing okay with their chronic disease. And they do feel more engaged and like they understand their chronic disease a bit more because they're monitoring it on a regular basis. They get these alerts up to 5 times a week. We can lessen that if it seems too much, but it definitely seems to give us good, strong satisfaction rates. Next slide. And same idea here. patients are just showing the right amount of frequency. Again, Katie can change and adjust that if they're feeling like they're getting too many messages and it is deterring them from wanting to stay in the program. But at the moment, we haven't done a lot of adjusting unless it's a customized thing for each patient.
And most patients are getting alerts or getting the messages twice a week is kind of the average. Very few are getting the 5 days a week. That would maybe be your diabetic patients with the blood sugar readings, but typically it's 1 or 2 days a week is what most patients are comfortable with.
Yeah, and that is another reason they're only in 2 chronic disease programs, because we don't want to overwhelm them if they have more chronic diseases with too many alerts or too many messages either. Next slide. And again, I think this health literacy really explains kind of that engagement we're seeing with patients. It helps them understand their disease a bit better, and then eventually if they ever go off the program, they in general just know how to manage their disease, chronic disease, a bit better. I feel like we've definitely seen that with these patients. Next slide. And just some different things we've heard from patients. I appreciate these texts. They help me keep a closer eye on my mental well-being and understand that I actually need to tell my doctor when I need help. We did see that with a lot with chronic care management. Traditional chronic care management is, you know, we sort of had to be at the right place at the right time, and these patients really learn when they need to engage us too over time. Next slide. So again, this allowed us to expand our value-based care and really increase cost savings beyond what we were already doing. We were just confident in this it helped us meet our downside risk in a very manageable way, and great outcomes are shown to us every quarter that we can share with our stakeholders. We can use to figure out if we want to dig in deeper. We're currently working, if we integrate into our TouchWorks, how do we maybe use our PHQ-9 data that we're getting from this programming to actually impact our quality measures. So just lots of things like that where that can be key takeaways. So it balances well that fee-for-service to balance value-based care. It focuses on high and rising risk patients, which we've never been able to do before. So it uses technology. It doesn't just grow care management, it grows efficiency. Again, we can go back and forth. We can take some people off of care management that was taking a lot of time and put them into more of this home monitoring type program. It identifies and manages the patients that need support. Again, Katie can refer to us as RN care managers if more is needed. Recognizes the prevalence and cost of mental illness and managed comorbidity conditions. We've never had that validation before, so it's been great to have that and show that to our administration as we build other programming around it. So all in all, it's just been a tremendous program to work with and be able to meet some of our quality measures, manage our patients, and really feel like we're taking care of them on a holistic level and staying ahead of their needs. Next slide.
And Garrett, we'll turn it back over to you. First of all, Nicole and Katie, you all talk about the Care Signal program far better than any of us at Lightbeam can. So thank you for everything that you're doing. Incredible results. And we're just thrilled and so honored by your partnership and your trust in us to deliver for you. Garrett, any questions? I think we have a few minutes.
Yes, for sure. Yeah, we don't have a whole lot of time, but we've got time for a couple questions here, and we did have some audience questions. And let's see, in no particular order here, it said, would you say the biggest success has been in improved patient care or cost savings? Are they both equally important?
I would say they're both equally important. Having a passion in care management, I'm going to say patient care, but I think admin would say it's really been nice to be able to prove that value-based care really does have an impact. It has a tremendous cost savings. And again, until Care Signal, we really could never put our fingers on that. Claims were delayed, and you tie that to care management or other wraparound type value-based care programs we have going on. This really helps tie that to what we're actually doing. And so I think both are tremendous for sustainability as well.
Great. Next question here is, do you have any idea why the savings for diabetes was relatively small compared to the other conditions?
I don't, because our A1C dropped tremendously. I'm not quite sure. We do have a diabetic center. So there could be multiple factors. We also have when we started out our care management program, we did focus very strongly on diabetes. So there was already a large number, at least, of high risk patients that were working with, at least with a traditional care manager. So that might have played a role. We do, however, see a drop for quality, which does impact our downside risks. So there's savings there, maybe less savings with ED and hospital utilization. And that would be my only thought. I don't know if Shelley has just with working with other partners.
Yep, oftentimes the investment into a diabetes program is an investment today that grows fruit down the road, because it is when it's, as you grow older, it's more challenging to manage diabetes and keep your A1C. And the fact that Mankato was able to get a 2-point drop, typically what we see are the complications, and that's where a lot of the expense comes in, is the cost of the complications of diabetes, that progression into the higher risk. And so you invest in the diabetes program today, you help to manage them and give them the tools to delay that progression. So they're going to see the results long term from a diabetes program standpoint.
And I think that was something Mankato Clinic always struggled to with those rising risk patients. It was hard to implement programs in there because that is commonly where you have that bind. You're not necessarily seeing cost savings. You may prevent cost savings more than you're seeing the actual cost savings in action. So we tended to look more at our quality measures to say whether we were meeting kind of the goals we had set versus cost savings with diabetes. Several other diseases too. I would say depression at times too. That's a hard one to actually say whether we're keeping them out of the hospital or not.
Sure. We have time for one last question, and actually, you inadvertently did a good segue into it. It says, can you speak a little bit more about how you define your quote rising risk population? Is it based on a specific amount or percent of change in their values, or is it more using clinical judgment?
Well, and Shelley might have something to add to this, but when in the world of care management, it's usually your top 2 to 5% you're focusing on. They're the patients that are costing us the most. So when we get risk lists and all sorts of things from our payers, you'll see them at the top of the list costing tons of money. As you do this work for a while, you do find that once they're up there, they're a little hard to move the needle. So you start talking about these, what we call rising risk or middle of the rowers. Research says about 20% live there. I don't know a lot about that research other than it does seem to equate to that, where they may be newly diagnosed or they're just starting to show the trend of maybe hitting the hospital or coming to the clinic unmanaged, or maybe not managing their disease by coming to the clinic. And if we could get ahead of them, we can prevent that cost. So again, sometimes it's hard to show the cost savings, but that's kind of how I know it looked anecdotally for us, was that there were just a big, large portion of these people that if we could intervene before they got to the high 2 to 5% of cost, that's where it would be. But I know there's risk lists and all sorts of things that Shelley might be able to explain a bit better.
Yep, we are data driven. And so we look at the data, and then we have evidence-based recommendations of who we would offer the services to. And then I think that Katie and Nicole spoke very eloquently about the ability to graduate and then escalate patients as need be, for resource management on our client side, so that that the team is focused on those acute patients, and they can graduate patients, but still keep an eye on them, still keep their arms wrapped around them, still be a vital member of the care team, and then escalate back as needed.
Wonderful. Well, unfortunately, we are out of time. Obviously, we have a lot more questions that came in. And by the way, if you have a question that you want to ask and wasn't asked, go ahead and drop it in now, and someone will get back to you through email later. We had a big audience today, so a lot of questions that came through. But I wanted to thank you all so much for the presentation today. This is this was great. Obviously, there's a lot here. And so if you want to reach out to the Lightbeam team, you see their information here on this slide. It'll also, we're going to send you over a link to the recording and to the slides, and so you'll be able to see that here. But you can reach out to them at info@lightbeam. So thank you guys so much. This was a wonderful presentation. As we wrap up here, I would like to encourage you all to head over to vbcexhibithall.com, and this is where you can actually visit the Lightbeam Health Solutions virtual exhibit booth, which is kind of cool. They've got a lot of different resources there, and you can read up on them and what they're doing in the space, really get yourself educated about them. And then, of course, there's ways to reach out to them from there. Or feel free to reach out to me as well, and I'm happy to facilitate an introduction if that's easier for you. But again, I wanted to thank you all so much for your time today. Thank you, ladies, for the presentation. Hope you all have a wonderful rest of your days. Bye-bye now.